Hello, this is Eustachian tube dysfunction, patient selection. My name is Edward McCool. I'm a rhinologist at the Department of Otolaryngology at Ochsner Health in New Orleans, Louisiana. The topic we're going to discuss today is the Eustachian tube dysfunction, by which we specifically mean obstructive Eustachian tube dysfunction. Published estimates place this at 2 million annual visits, ambulatory care visits for Eustachian tube dysfunction in the United States every year. Other studies have indicated 43% of patients with symptom scores who are assessed for presentation to otolaryngology clinics have symptoms that are consistent with Eustachian tube dysfunction, even if they're not formally diagnosed. And other assessments of symptoms, such as the SNOT-22 or sinonasal symptoms, are strongly correlated with the presence of symptoms related to Eustachian tube dysfunction. Patients with sinonasal disease may be at risk for Eustachian tube dysfunction, and these patients may represent a population that's particularly amenable to techniques such as balloon dilation of the Eustachian tube, which may be considered with or without adjunctive procedures for sinonasal treatment. So historically, there are as a sequence of treatment options, beginning usually with medical therapy. The benchmarks for this are topical intranasal corticosteroids, oral corticosteroids, decongestants, antihistamines, and any other sinonasal pathologies such as allergic rhinitis to be treated with appropriate therapy there. Patients who have Eustachian tube dysfunction that does not improve with some of these measures then may require intervention. And traditionally, the intervention has been myringotomy or tympanostomy tube placement, or PE tubes. But the downsides of this, while it does result in reliable symptom relief, it's also something that's not permanent. It's a bypass, but it's not a permanent one. And generally, the tubes are extruded and within 12 to 18 months and may need to be replaced. Lifestyle modifications such as environmental changes or dietary changes may be useful for these patients, may be required, as well as avoidance of water activities because of the presence of a tympanostomy tube placed. And the risk of a persistent tympanic membrane perforation after the tube extrudes is also significant. The treatments available for the Eustachian tube include dilation of the Eustachian tube, which is an exciting development over the past several years. The Express device is suited and has been FDA approved for treatment of the Eustachian tube dysfunction by balloon dilation. There have been several clinical studies published, the results of which show symptom improvements ranging from 64 to 98%, and the number of patients treated number in the thousands, with follow-up data up to 2 years and a very, very low complication rate. But before we get into the treatment, it is important to discuss the diagnosis and to establish who these patients are that stand to benefit from a treatment of the Eustachian tube, such as balloon dilation. First of all, diagnostic criteria are not fully defined. There is emerging evidence in the literature to support a multifaceted diagnostic approach. So there's no single test that is uniformly diagnostic. The symptoms tend to be characteristic, and they can be summarized by this instrument, which is a patient-reported outcome measure called the ETDQ-7. And there are 7 items, as you can see, and they're graded as being no problem or severe problem or somewhere in between. pain and pressure in the ears, and feeling of being clogged, muffled, popping, cracking, or ringing in the ears. These are all suggestive of eustachian tube dysfunction. Additional assessments include the pneumatic otoscopy, the use of a Valsalva maneuver, and tympanometry, such as, in other words, audiometry, as adjuncts to support the diagnosis. More generally, the patient presenting with oral phoniness, you want to have these elements I've discussed, as well as a physical examination, and typically nasal endoscopy or fiber optic endoscopy to look for signs of inflammation in the eustachian tube or the nasopharynx, as well as audiometry. These are the elements of the history that have been alluded to. The symptoms of eustachian tube dysfunction, notably, some patients are strictly unilateral, others they're bilateral. They may be brief, they may be persistent, they may be variable with the situation. They may be associated with hearing loss or not. Importantly, some patients have a significant relationship of their symptoms to changes in barometric pressure, and we're going to talk about that. Important parts of the past medical history include a recurrent or chronic otitis media, presence of allergies or atopic disease, reflux disease, particularly extraesophageal reflux, chronic rhinosinusitis or recurrent acute sinusitis, diagnosis of polyps, or for that matter, presence of sleep apnea, which may be associated with some of these other symptoms. And the history of head and neck malignancy or radiation therapy of the head or neck also significantly increases the likelihood of eustachian tube dysfunction. The previous history of surgical treatments, including tympanostomy tubes or adenoidectomy, suggests long-standing dysfunction of the eustachian tube, as does the history of cleft palate repair or prior sinus surgery, and those should be elicited. And then medications and environmental factors such as smoking, and occupational factors such as frequent air travel or use of elevators is also important. So some of the key questions are, can you pop or clear your ears at rest? If you can, that is actually a good sign, but it's the patients who cannot pop them or cannot pop them reliably or in both ears, those are the ones that tend to have an obstruction that needs to be relieved. Do they get the symptoms when they fly or dive or take an elevator is also important. And if they've had prior ear tubes, did it give relief? That's important, because if they did not get relief from prior ear tubes, then balloon dilation is probably not going to help them. We talked about patient-reported outcome measures. The ETD-Q7 is the most widely used for assessing symptoms of oral fullness. That can be supported by other measures such as sinonasal outcome test, of which there are 22 items. It's the SNOT 22. There are other sinonasal related measures that can be used as well. And taking these both at baseline, pre-treatment, as well as post-treatment to assess changes is a good idea. A physical examination, most importantly, would include otoscopy, and you're looking for a retraction of the tympanic membrane or the presence of fluid. And also, you are looking for if the retraction is mobile or if it's adherent to the middle ear space. And it's also worth looking for an ipsilateral breathing test, which is something you ask the patient to occlude the contralateral nostril, and you watch their tympanic membrane as they breathe. And this is important because of the diagnosis of patchless eustachian tube dysfunction, which sometimes has similar symptoms, can be identified by the positive finding on the ipsilateral breathing test. Also, in the diagnosis, or the differential diagnosis of oral fullness, is eustachian tube dysfunction is also tympanic or temporomandibular joint dysfunction. And so TMJ can be teased out by palpating the muscles of mastication, the temporalis and the pterygoid muscles inside the mouth, and also looking for signs in the nose that would suggest sinonasal pathology. I mentioned nasal endoscopy and fiber optic pharyngolaryngascopy. Looking for signs of inflammation at the eustachian tube is really potentially easily overlooked as an important part of the evaluation. But you can learn a whole lot if you see any sort of edema, erythema, or even mucus cascading over the orifice of the eustachian tube. These suggest obstruction. Also, this helps to identify extrinsic obstruction or compression of the eustachian tube orifice, such as adenoids or even a tumor or antroquinal polyp. And these things can cause eustachian tube dysfunction externally. So when you examine them, I recommend asking the patient to phonate, or using the phrase such as Coca-Cola or ka-ka-ka is highly effective to see the muscles contracting and seeing the lumen open and close. And also looking for signs of extraesophageal reflux, such as post-cricoid edema, can be useful as well. We mentioned audiometry, and this includes pure tones, but also crucially tympanometry, looking for a type B or type C or negative pressure tympanogram is nearly diagnostic of eustachian tube dysfunction if it's present. So that brings us to the clinic and to our office where we're seeing these patients. And what type of patients come in with symptoms of orophonus and possible eustachian tube dysfunction, and what do they look like? Well, there is potentially dozens of nuances to this, but I think it's useful to break it down into several categories, 5 or 6 categories of patients that commonly present. And so we've outlined them here. That this is our big 6, and I'm going to go through each one of them one at a time, and keeping in mind that these are not hard and fast rules. These are not based on strict epidemiologic criteria. These are more based on years of clinical practice, as well as what's been the patients that have been included in the studies that have been done in the past decade. So first up is the frequent flyer. And this type of patient has symptoms, particularly during air travel, and especially upon descent, or more generally, any sort of baro challenge or change in ambient pressure. The symptoms they may have difficulty equalizing the pressure, and this lasts for hours or even days after they land. They do get relief often with decongestants, but when you examine them in the clinic, you may not see anything abnormal. And so these patients may be a candidate for balloon dilation of the eustachian tube on the grounds that they have an anatomic narrowing that is relevant when they are baro challenged. So a typical patient would be a 40-year-old adult male who travels frequently for work, travels coast-to-coast flights, and this is a reliable, consistent symptom. And it causes a significant burden on his quality of life because he gets where he's going and he has to go to meetings, but he's feeling all this pain and pressure in his ears, and it's disruptive. Notably, patients like this may have had tympanostomy tubes in the past, and they actually got relief until the tympanostomy tubes fell out. And so treatment options include repeated sets of PE tubes. If decongestants are not effective or not desirable, then balloon dilation of the eustachian tube can be a very good option for these patients. Second type of patient I call the newcomer. This is someone who did not always have ear problems. As a child, they didn't necessarily have ear problems, but sometime in adulthood, they developed this feeling of orophonus. And oftentimes, for obscure reasons, this tends to be one-sided. And these patients, in contrast, when you see them in your office, they will have objective findings of contracted eardrums. They'll have an audiogram that shows a type B or even a type C. And oftentimes they have coexisting sinonasal disease, mild perhaps, history of allergies, sniffy nose or itching or sneezing seasonally. That's not always the case. Typical example would be a woman in her 30s who has had oral phonus, which may be unilateral or bilateral. As I mentioned, they have this feeling of muffled hearing, and they've had allergies in the past. This person may have had allergy shots even, and you see these findings of middle ear, negative middle ear pressure. So a reasonable course of action is to try to treat their allergies, make sure that they're adequately treated with the sprays or antihistamines as appropriate. You can offer them tympanostomy tubes, but you can also now offer them a balloon dilation of the Eustachian tube in order to reestablish the ventilation of the middle ear, which is causing these objective findings. Third type of patient is similar in the sense that they didn't always have Eustachian tube or oral phonus problems. This happened one day, one acute episode in their adulthood, and this type happens after an upper respiratory infection. So in contrast to the patient I just showed you that has sort of a gradual onset, these patients have a defined time, and they say it all started when I got a cold, last January, for instance. And these also are typically unilateral, they may be bilateral. And also in these cases, you'll find that there is a significant retraction, and there'll be abnormal tympanograms. However, these patients usually are self-limited. And it's worth noting that Eustachian tube dysfunction that starts after an upper respiratory infection, either viral or bacterial, it is usually self-limited. And so the general recommendation is to wait at least 1 month and typically up to 3 months for it to resolve. After 3 months, then you can say, well, this has become a chronic problem. And then you can consider interventions. So this type of patient, for instance, a 45-year-old man, and he has right-sided oral phonus. It's been about 2 months. Started during a URI, and you see he has effusion in his ear, and he actually has a small earbone gap on pure tone audiometry. So this is someone that you would want to allow to have some spontaneous resolution. You treat them with decongestants or steroid sprays. You might even consider a myringotomy if they're having significant symptoms, but you could also consider balloon dilation, especially if it becomes chronic. If they want quick relief, if they have some extenuating circumstances that they need quick relief for, you could consider a balloon dilation even acutely. But certainly if this does not resolve within 3 months, then that is a good option. The fourth type of patient that you may see, I call the sinus sufferer. And these sinusy types tend to have year-round symptoms that they don't really remember when it began. It's been going on a long time, and their main symptoms are usually not the ears. Their main symptoms are nasal, sinonasal. They have congestion, postnasal drip, pressure. But generally, they're not relieved by antibiotics. They may be relieved by antibiotics temporarily, or steroid shots, or oral steroids, but the symptoms tend to come back. And when you look in their ears, they may have a normal-looking eardrum. They may not have fluid. They may have a normal tympanogram. And so these patients do not have intrinsic Eustachian tube anatomic narrowing in the same way that other patients do, the ones I've just shown you. These are probably related strictly to inflammation, and the inflammation derives from the fact that they have chronic sinusitis. And that's what all these symptoms are pointing towards is chronic sinusitis. So like the 53-year-old woman who's had bilateral ear phonus for at least a year, but at least that long and probably longer she's had these sinonasal symptoms, a hyposmia and postnasal drip and so on. And when you do her examination, and this is where the workup with nasal endoscopy is also important, you can identify comorbid sinus disease, such as polyps in the middle meatus. And so they may have abnormal tympanometry or abnormal audiograms, or they may not. But the point is that they do have chronic inflammation and they have chronic sinusitis. And so someone like this, eventually, statistically, 25% of people with chronic sinusitis are going to eventually need sinus surgery. And so once you've gone through the usual treatment options, you offer them sinus surgery. And if they do have eustachian tube dysfunction as part of this, or symptoms suggestive of it, then offering a concurrent balloon dilation of the eustachian tube, either with sinus surgery or with a balloon dilation of the paranasal sinuses, then doing those procedures together is a reasonable option. The fifth type of patient I call the lifer. And this is one who has always had ear problems. As a child, they had ear problems. They had lots of sets of ear tubes. They've been through it all. This often is unilateral, surprisingly, although it can be bilateral. And these are patients that do have objective findings as well. When you see them as an adult and you see them in your office, they have type B or C tympanograms, and they have retracted eardrums, and they may have fluid. And they've tried it all. They've done the sprays and the antihistamines, and they've had the ear tubes, and their symptoms just come back. 35-year-old woman, left-sided symptoms, all of her adult life, going back to teenage years. And notably, as I had mentioned, the importance of can they clear their ears? So you ask them to do what's called a modified Valsalva. To clear the ears, and if they're unable to, that's important for part of the diagnosis. They don't really have sinonasal symptoms, but they have type C tympanograms, retracted eardrums, and there's really only two reasonable options for this, because there are no medical therapies that are known to or have been shown to be specifically helpful for this type of case where there's no other condition present other than eustachian tube dysfunction. And so your options are tympanostomy or myringotomy, or balloon dilation of the eustachian tube, the latter being having the favorable aspect of it addresses the natural underlying cause, or the dysfunctional organ itself, rather than bypassing by placing a tube across the tympanic membrane, which is, as you realize, an artificial fix. The sixth and last type of patient that I'll just mention is what I call the puzzler, because they have symptoms that in many ways are similar to the previous patients. They have oral phoniness, they don't have hearing loss, and they don't have symptoms of patchless eustachian tube dysfunction. They don't have tympanic membrane, they don't have TMJ symptoms. Generally, it's both sides, but they have symptoms, and their ears look fine, their audiograms are fine. These patients I would be very careful about. These are patients who probably do not truly have obstructive eustachian tube dysfunction. They have something else. They may have inflammation in that area, or maybe nasopharyngeal inflammation, but they don't have a fixed obstruction or anything causing a objective finding. So trying to do any intervention, surgical intervention, including balloon dilation of the eustachian tube, is not advised. So now to talk a little bit about the procedure itself of the balloon dilation. There was a clinical consensus statement that was published last year in a major journal, which divided these eustachian tube dysfunction into two different categories of reliable symptoms. One is the patient who has static obstructive ETD. As I mentioned, there's several months or more. symptoms of oral phoninus with or without hearing loss, and you have objective findings on otoscopy and objective findings on tympanometry and objective findings when you do a nasal endoscopy. Contrast that with patients who do not have symptoms at baseline, but they have them when they're barochallenged. And most of the exam will seem normal, although if you do nasal endoscopy, you should see some type of inflammation or suggestion that the nasopharynx orifice is not completely normal. So this is just a video that shows the general technique of inserting the catheter and the device. This is the express device being placed into the nasopharynx and under endoscopic visualization, and being placed at the correct angle into the lumen of the eustachian tube. Now, there's depth markers that are marked out in centimeter hashes, and so about a 2 centimeter insertion is the max that you want to go, because the eustachian tube is between 3 and 3.5 centimeters in length, but the last centimeter and a half or so is bony, so you don't want to advance into the bony portion of the eustachian tube. And then you advance the balloon and then inflate it as per the instructions. So much of the evidence comes from a randomized controlled trial that was done recently, and 1-year follow-up was published recently. Patients that limited to adult patients 18 years old or greater were randomized to have either balloon dilation versus a medical management, which was topical nasal steroid sprays. The patient inclusion criteria were those who had significant symptoms as defined by the ETDQ-7 for at least 12 months, and you see that here. And they had failed medical management with nasal steroids or oral steroids prior to that. And these patients, the outcomes found that the primary endpoint of improvements of eustachian tube dysfunction questionnaire symptoms, there was a significant reduction in the group with the dilation compared to those in the controls, and you see that in the chart here, and that was a pretty convincing finding, given that many of these patients did not reliably have objective measures that were identifiable, such as not all of these patients had abnormal tympanograms, but yet they had elevated eustachian tube symptom scores, and there was improvement across the board, and notably no complications of any significance reported here. So this graph also shows the time course and the durability of the symptom improvements. 2.1 is considered the cutoff for essentially an asymptomatic state. And so you see they went from a mean of 4.6 at baseline to 2.1 at 6 weeks, and you can see that the durability out to 12 months was essentially unchanged. At follow-up, these are the individual symptoms that compose the ETDQ-7 score, and you can see it wasn't just 1 or 2 symptoms that it accounted for the improvements. It was really across the board. And in summary, the overall changes, both 1-year follow-up as well as later study looking at long-term follow-up with a mean of 29 months, the significant improvements persisted. The normalization of tympanic membrane position, the ability to perform a Valsalva maneuver, and the normalization of tympanometry all persisted in the 60 to 70% range of long-term results, long-term improvement. And so in the sake of completeness, I should mention there are a few contraindications to balloon dilation of the eustachian tube. I've shown you the patients, the cavalcade of patients, many of whom would expect to improve, but the contraindications would be patients who have been treated definitively for eustachian tube dysfunction, such as specifically with tympanostomy tubes or myringotomy. They were treated but did not improve, even with a functioning PE tube in place. That's a warning sign that if they didn't improve by that, they're not going to improve with the balloon dilation. And the reason being they don't actually have the diagnosis of obstructive eustachian tube dysfunction. Second type of patient would be one where the tympanic membrane is adherent to the middle ear structures, the promontory or the ossicles. And so you may relieve the pressure by opening the eustachian tube, but it still doesn't allow the tympanic membrane to vibrate or have excursion the way it needs to be. These are patients, and this is a bit outside of the scope, but these patients may benefit from tympanoplasty or actual middle ear surgery. Thirdly, a patient with severe nasal obstruction, if you can't get to the eustachian tube or the nasopharynx with your instruments, then you can't do a procedure. And this is one reason for doing nasal endoscopy as part of the workup. If you have a severe septal deviation or large polyps or large turbinates for that matter, that would prevent you from doing a dilation unless you were to concurrently fix those obstructions. And the last issue is the presence of abnormal anatomy of the carotid canal. So I've mentioned that this technique is designed only to dilate the cartilaginous portion and not the bony portion of the eustachian tube. Now, that being said, the carotid is in the proximal part of the bony canal. So if there is a CT evidence on a CT scan or imaging that shows dehiscence or a non-protected carotid in proximity to the eustachian tube, you would avoid doing a eustachian tube manipulation of any sort in this patient. That being said, the Express device is FDA approved, and it has those safety features, including the depth markings and the stopper at the tip of the catheter that prevents insertion too deep and prevents insertion into the bony canal that would endanger, it would cause a complication from that. So using a device such as the Express is certainly recommended and is not a contraindication in that case. Thank you very much.